A big thank you to the organizers for giving me this opportunity to speak on the latest updates in extensive stage small cell lung cancer. So small cell lung cancer has been without much updates, and it's very heartening to see the latest updates that have taken place in this field. So globally, as we can see here, the incidence of small cell lung cancer differs by the continents as well as the countries. And Asia is still much less than the Americas. So the 5-year survival, this is what is very morbid about small cell lung cancer. We all know about it. So it is very low as seen in this slide here. The staging slightly different from the non-small cell lung cancer, though the TNM staging is also advocated, but we generally are following the veteran staging of limited stage and extensive stage. So most of our patients do come in extensive stage, which is about 65 to 70% of our patients. The approaches to treatment, I will skip the stage 1 and the limited stage diseases where we all know it is chemoradiation with or without PCI. And in the stage 4 disease, that is extensive stage small cell lung cancer, the standard of treatment was for many years only chemotherapy, and now it has shifted to the first line treatment has shifted to immunotherapy plus minus consolidation RT or PCI, and of course in second line we have many more agents which I will be discussing. So I will not go into the details of the rationale behind immune checkpoint inhibitors, which you are all very well aware of by now. So suffice it to say that PDL1 expression has been observed in a significant proportion of small cell. There are varying reports. Some say that it is less and some say it is high. So important thing is that PDL1 positivity per se is associated with a better prognosis compared to PDL1 negative small cell lung cancer. And this we all agree that the tumor mutational burden definitely is high, being a smoking associated, predominantly smoking associated disease. The neoantigens and the mutational burden is higher compared to many other cancers. So immune checkpoint inhibitors have been one of the most important developments in the first line treatment of small cell lung cancer. And as you can see here, these are the multiple studies that have been done. The blue ones are the phase 3 trials and the gray ones are the phase 2 trials. And I will take you through the important trials. I will summarize them for you and highlight what is the major advantages from the addition of this immune checkpoint inhibitors. So PDL1 inhibitors have performed better compared to PD1 inhibitors. So there are two of them which we now know very well of. One is atezolizumab and other is durvalumab. So the IM power 133, which used atezolizumab with chemotherapy. So here the chemotherapy backbone was carboplatin and etoposide, and for 4 cycles, followed by atezolizumab maintenance, and the control arm was placebo. So I shall highlight the differences between the trial which used atezolizumab and the trial which used durvalumab. The Caspian is the name of the trial which used durvalumab, and here cisplatin or carboplatin along with durvalumab. 4 cycles followed by durvalumab maintenance, and in the control arm 4 to 6 cycles was allowed. And now the trials with the PD1 inhibitors, that is pembrolizumab and nivolumab, which are performed very well in non-small cell lung cancer. The Keynote 604 study again used pembro with the platinum backbone and etoposide for 4 cycles followed by pembro maintenance, and etoposide platinum for 4 cycles followed by placebo maintenance. And this trial also did not allow unstable brain metastasis, treated brain metastasis only. And the ECOG Acrin EA5161 nivolumab 360 mg along with cisplatin or carboplatin etoposide followed by maintenance again. So all these trials are very similar in their design and the endpoints, which was PFS and OS. So what we can see from the summary of all these trials is the consistent benefit. So if we go by NCC and evidence block, the consistency of benefit and the phase 3 evidence is that we can see here. Consistently, there is improvement in PFS and OS, as we can see here. The PFS has been about 5 months approximately, and the OS has varied from 11 to 13 months, depending on the trial. So there has been a consistent benefit by adding immune checkpoint inhibitors to chemotherapy. The PD1 inhibitor trials, that is the Pembro and the Nivo trials, Keynote 601 and EA5161, they could not achieve statistical significance. Otherwise, the magnitude of benefit approximately was the same compared to the PDL1 inhibitors, that is durvalumab and atezolizumab. And as we can see here, the 24-month survival, again, all stabilizing at around 20% rate. So they are showing a consistent benefit, which definitely gives us a lot of confidence in adding these agents to in the first line setting. So the between these two important agents, that is durvalumab and atezolizumab, there were some important differences in the trial. Untreated brain metastasis was not allowed in the atezolizumab arm, whereas it was allowed in the durvalumab trial. And cis or carboplatin both were used in the durvalumab trial compared to only carboplatin in the atezolizumab trial. And 6 cycles of chemotherapy was allowed in the control arm in the durvalumab trial with an optional PCI. So in the durvalumab trial, because even untreated brain metastasis as well as treated was allowed, so we can see here there was a consistent benefit in the OS even with brain metastasis and without brain metastasis. So a mild difference between these two trials, which may help us in selection of agents in specific patients. So to summarize, addition of immune checkpoint inhibitors to platinum etoposide backbone significantly improves survival in advanced small cell lung cancer. And safety outcomes are consistent with known safety profiles of each agent. I am not going to the details of safety of these agents because it's all well known. Again, immune checkpoint inhibition plus chemotherapy now has become the standard of care without doubt. Now for the updates in the second line setting, in the recurrent setting, topotecan, as we all know, was the approved agent. And it has got some evidence, but the main worry for us is the toxicity. So the new agent that has been approved, though I think not yet available in India, is lubrinectedin. So this was approved based on the single arm phase 2 trial. And as we can see here, this agent, which is an alkylating agent, it performed well, better in patients who had a treatment-free interval of more than 90 days. So this is the right-hand side of this table here. So we can see the median OS is 11 months in the treatment-free interval more than 90 days, and only 5 months in the treatment-free interval less than 90 days. So this agent was, the most important part of this agent is the benefit with its toxicity. Compared to topotecan, the hematological toxicity is much less. And that perhaps is the major factor going in favor of this agent. Now, combination trials of these agents have been tried with doxorubicin, but with a lesser dose, and those have not shown this significant benefit. So that has been a dampener as far as this agent is concerned. Trilaciclib, as I think it is coming up in many other cancers also. So we all know it's a short-acting CDK4/6 inhibitor. Now, it is not an anti-cancer agent per se here. It is being used as a myeloprotective effect, and it is being tried with chemotherapy. And the toxicity of chemotherapy has been found to be much less when we use this agent. It got a myeloprotective effect. So now, as immunotherapy in the second line, supposing you have used only chemotherapy in the first line, the role of immunotherapy in the second line. So at the bottom of this slide, as you can see, again, the Checkmate and the Keynote trials have shown consistent PFS benefit. And all these trials show that towards the tail end of the curve, there is a plateauing of the curve, and about 10% of the patients have a longer survival, which is a good thing, definitely. Now, to come to the even latest updates, that is the research that is going on. So just to give you an idea of what are the latest research that is going on in extensive stage small cell lung cancer. So the TIGIT, the immune checkpoint inhibitor targeting TIGIT. TIGIT is an inhibitory receptor on the T and NK cells, and tiragolumab is a fully human anti-TIGIT monoclonal antibody. The skyscraper trial is using tiragolumab along with atezolizumab and chemotherapy also. That's not mentioned yet. So chemotherapy is also part of the trial. It's a first line trial, and this hopefully will show us some much better benefits than only immune checkpoint inhibitors. So the other is the agent called as BMS 986012. It is targeting the anti-fucosyl GM1. So again, the combination with nivolumab here in small cell lung cancer, this is also showing promising results. nivolumab and chemotherapy. Liposomal irinotecan is another agent which is coming up in small cell lung cancer. The advantage with this agent, it is long acting. It has got a T-half of 26 hours and a prolonged topoisomerase 1 inhibition. So it gets about more than 5-fold higher levels in tumors compared to plasma in 72 hours. So this is also showing this is a resilient study. Liposomal irinotecan. So the dose again is much lower than the irinotecan, the normal irinotecan which we use. So this is in an expansion phase trial now, and hopefully this also is going to get us some good results. Now the PARP inhibitors are also being tried in small cell lung cancer, and the gene called as SLFN11. So it has been found to be an important determinant of PARP inhibitor sensitivity, and the ones that are positive, along with velaparib and temozolomide, has a combination of this has shown some good results in the second line setting. Now, Aurora kinase inhibitors are rather is a group of drugs where alisertib is one of the Aurora kinase inhibitors. Now, this agent is along with paclitaxel chemotherapy is showing some benefit in the c-MYC positive tumors, as we can see. So again, some promising results. Now, DLL3 is another important marker on the tumor cell. A bispecific T cell engager or an antibody has been tried already. So there was a trials with an agent called as ROVO-T, which did not show the desired results. So now a newer agent called as AMG 757, again a bispecific T cell antibody targeting DLL3 in small cell lung cancer is being tried, and the early data from the phase 1 trials are showing promising results. So the key take-home messages on the updates in small cell lung cancer is that the first-line treatment for extensive stage small cell lung cancer for most patients is definitely a platinum etoposide with a PDL1 antibody. In the second line, lubrinectedin is a new option for recurrent second-line small cell lung cancer, mainly because of its superior toxicity profile to topotecan. Trilaciclib can reduce the hematological toxicities if available. It's a good agent to use. And there are multiple newer strategies that are being pursued in the clinic, including the TIGIT, the fucosyl GM1 antibodies, the Aurora kinase inhibitors, PARP inhibitors, and the bispecific antibodies targeting DLL3. Thank you, and I will be happy to take any questions if there are.
Thank you, Suresh sir. The forum is open for any questions.